But good evening. Thank you everyone for joining us for tonight's presentation, Inside Emergency Medicine with Dr. Brian Desaulniers, Washington College class of 2004. After Dr. Desaulniers' initial presentation, there will be time for questions. Dr. Desaulniers graduated cum laude from Washington College with a BS in Biology and Environmental Studies and a minor in Business. He went on to receive his MD from the University of Maryland School of Medicine in 2008 and completed his residency at Palmetto Health Richland in Columbia, South Carolina. Dr. Desaulniers is Vice President of Emergency Service Associates, which is a 19-position partner group based in Salisbury, Maryland, and is also the Assistant Medical Director for the TidalHealth Peninsula Regional Emergency Department. Dr. Desaulniers, thank you for joining us. I'll turn things over to you.
Awesome. So I thought I would just kind of talk a little bit about my path to get to where I was now, and also a little bit about what I'm doing acutely now. So my path was that I began at Washington College in 2000, right out of high school. I was at Washington College from 2000 to 2004. I was lucky enough to be taught by the great Dr. Kate Burville, and she was very influential in helping me get into medical school. When I was in college, I certainly did a lot of things that I think most people at Washington College end up doing, and that's not concentrating solely on how am I going to be a physician, but concentrating on how I'm going to be a human being. I spent a lot of time taking English classes, actually, and wound up with an English minor. And I also got involved with environmental studies, wound up getting a second major in environmental studies with Dr. Munson, because I really enjoyed his teaching. And then after my first 2 years at Washington College, I decided that I thought medicine was what I wanted to do. Dr. Burville actually was very helpful in setting me up with a pediatrician in Washington, D.C., which I spent some time with because I thought that I wanted to do pediatrics. I really enjoyed that time. I knew that I wanted to do medicine, and also made the realization that I absolutely did not want to do pediatrics. As much as I love taking care of sick kids, I do not enjoy taking care of well kids. It just wasn't my thing. And so I changed course a little bit. My third year of Washington College, I went and got my EMT certificate, and I started running calls for the Kent and Queen Anne's Rescue Squad. I was part of them the last 2 years I was in college, but also continued with them for the 2 years subsequent to that, as my now wife was finishing her 2 years at Washington College. She graduated in 2006. And so I spent 4 years with the Rescue Squad. That was very, very influential in my decision to pursue emergency medicine as a career. I think once I started doing stuff with Kent and Queen Anne's Rescue Squad, I knew that if I was going to be a physician, that it was going to be in emergency medicine. Towards the middle part of my junior year at Washington College, I took the MCATs, did okay, and was accepted into the University of Maryland School of Medicine. I started University of Maryland School of Medicine in 2004, graduated in 2008. For those of you thinking about pursuing this as a career, I can honestly say that the first 2 years of medical school were by far the most difficult of any schooling I've done then or since. Those first 2 years of med school are quite tough. However, the second 2 years of medical school were awesome. And I really hit my stride then. Decided in my third year that I would take electives in emergency medicine. Fourth year of med school, did that, and took multiple different electives. One at University of Maryland, obviously. I did a rotation at Geisinger Medical Center, which is in northern Pennsylvania, towards the Scranton area, and ultimately knew that it was exactly what I wanted to do. Following that, in the fourth year of medical school, you apply for something called the match. You don't know what the match is. The match is kind of like sorority rushing. You preference the schools that you want to go to for residency, and they in turn preference you. So I think I interviewed at 14 different programs across the East Coast. After that whole interview process, I chose University of South Carolina in Columbia, South Carolina. The program's name is Palmetto Health, but it's University of South Carolina. I chose them as my number one, and they ranked me high enough that I got in. And so that's where I went to residency. My wife and I then moved down to Columbia, South Carolina. I did 3 years of residency in Columbia. And following my residency, we were trying to make the determination of where to end up. One of the really important things for me was to end up in a place that was a democratic emergency medicine group. And what that means, it means that the people who are actually practicing medicine are the ones that are running the company. It's a thing that doesn't exist in many places nowadays. In fact, there are only 2 groups left in the state of Maryland. We happen to be one of them. We take great pride in that. And so when we were finishing residency, we debated about whether staying in South Carolina or coming back to Maryland. My wife happens to be from the Salisbury area, and I love the Eastern Shore. And so we settled on coming back to Salisbury. And that was in 2011. I've been here since 2011, practicing emergency medicine at TidalHealth Peninsula Regional, otherwise known as Peninsula Regional Medical Center. It changed names about 1.5 years ago. My group also, like I said, it's an independent group, so we have contracts with TidalHealth Peninsula Regional, TidalHealth McCready, which is a very small freestanding emergency room in Crisfield, Maryland, Atlantic General Hospital, which is a community hospital in Berlin, and we are actually slated to take over the contract at TidalHealth Nanticoke in Seaford, Delaware in March. And so I've been in practicing medicine all of these years, which I've thoroughly enjoyed. I kid with people all the time that the best part of my job is being a physician and seeing patients. But I also do a lot of things that are not seeing patients. I do about 2/3 of my time clinically now, and I do about 1/3 of my time non-clinically. And so non-clinically, I make the schedule for all of our physicians and advanced practice practitioners, otherwise known as the nurse practitioners and physician assistants. We have about 30 physicians. We have 18 partners at this time. And then we have about 10 APPs that I make the schedule for. I also am the vice president, so I help with contract negotiations at our different facilities. And then I'm also the assistant medical director at TidalHealth Peninsula Regional. And that job is running the day-to-day ins and outs of the ER, making sure that when there are problems that arise or issues that they get dealt with. And I've been in that role for about 2 years. I've been vice president for about 4 years. I think Washington College did a great job of laying the framework for me to be able to even get into and pursue medical school. And I think it also laid the framework for me to be successful now in doing what I'm doing, especially when I'm spending about 1/3 of my time not really practicing medicine. They don't teach you in medical school how to run a business. They also don't teach you how to run an emergency department. They teach you how to be a doctor in medical school and residency. But some of those other things come with other experiences and also firsthand working through the trenches. So that's kind of my course. I now, like I say, practice in Salisbury primarily, but at all of our hospitals, I do practice that. And yeah, that's kind of where things are at this moment.
I know it's probably difficult to describe this, but can you walk us through maybe what a typical day would look like for emergency medicine? I know it's probably not really a typical, but just
So I don't ever have a real typical day. I think probably a good way to do it is tell you about maybe my last 72 hours. So for instance, Saturday morning, I woke up, I worked a shift from 7 a.m. to 4 p.m. So I went into work at 7 a.m. I saw patients all day, got off at 4 p.m. Came home, got to have a nice dinner with some friends, woke up on Sunday. I got to have most of my morning to myself. I got to watch most of the Ravens game, which was horrible, and then go into work at around 4 p.m. So I worked on Sunday from 4 p.m. to 1 a.m. I got home about 1:30 in the morning. I then went back to work at 10 a.m. yesterday, and I had meetings from about 10 a.m. to 2 p.m. And so when I say I had meetings, I actually had a couple of things that I had going on. I had some non-clinical things to do for the department. So we meet for things such as like, how can we improve our sepsis quality of care in our department? How can we improve our trauma care in the department. So I had a trauma meeting yesterday from 12 to 1, for instance. I then had a shareholder meeting at 1 p.m. lasted until 2 p.m. To discuss issues going on with our company, more of our business side of things. And then I went to work from 2 p.m. to 11 p.m. Got off work about 11:30 last night, came home, went to bed, woke up this morning, went in at about 7:15. Actually ran a lecture. We do a lecture series with, what we try to do is have some of our specialists, such as neurology and cardiology and OBGYN, come in and talk to the emergency physicians and APPs via Zoom about different things. So we had a lecture this morning. Had some other non-clinical things to do, and I got out of there about 9:30, 10 o'clock this morning. And I've been home since, and I had the rest of the day off. And so I didn't have to do anything else today, and I'm actually off tomorrow. That's kind of a pretty good overview of what my life is day to day, like over the past 3 days, because it does vary. And I think if you're going to do emergency medicine, you have to be willing to understand that your life is going to vary, because there are people getting sick at all hours of the day. So we work shift work, we work different shifts, and in any given day, for instance, we have 8 different shifts at TidalHealth Peninsula Regional. So I could go to work as early as 6 a.m. or go in as late as 9 p.m. So it just depends on the day.
I'll open it up for any questions, whether in the room or online, if somebody wants to hop in.
I see one in the chat room, so I'll grab that one. What is some of the stuff you've seen in the ER? What is the most common injury you see? So I think the most common complaint that we see in emergency medicine across the board is abdominal pain. Second is chest pain. We see normally about 15 to 20% of our patients experience trauma. So trauma is what you would more define as an injury. Probably the most common traumatic injury that we deal with are head injuries. That's probably the most common. We are down here at TidalHealth a level 2 trauma center. What that means is that we actually are the only level 2 trauma center on the entire Eastern Shore. So with the exception of where you guys are, which gets flown over to Baltimore, we take care of all the traumatic injuries down here on the lower Eastern Shore. So we see a fair amount of trauma. We have a full trauma team. As emergency medicine doctors, we are the ones that primarily evaluate those patients, and then we have a trauma surgeon to back us up if patients need to go to surgery or if they need to have specialized procedures done. We do also send patients to shock trauma in Baltimore if they're highly complex, after we stabilize them initially.
How has COVID changed kind of the day-to-day practice of emergency medicine?
That's a really good question. I think COVID did a lot of things. When it first hit, it definitely put us all on the radar that, we need to be prepared for all of these patients that would be coming in. And what the interesting part was is that, when the initial lockdowns happened, our patient visits went down by about 2/3. So on a typical day, we were seeing upwards of 300 people. We all of a sudden started seeing less than 100. And that trend lasted for a few months, slowly began to pick up. But our volumes last year were down from a high the year previous of around 90,000 to about 65, 70,000 last year. So we saw a big decrease in volume coming to the emergency department. Interestingly, now we're seeing a great increase in the number of people coming to the emergency department. Some of it is COVID. This little blip we've been going through right now is starting to slack off, which is good. But we've also found that there's a lot of people coming to the emergency department now that haven't been having the normal primary care that they otherwise would have. And so we're seeing complications of chronic illnesses that we had not seen so much in the past. Think, for example, of people with diabetes who haven't been taking care of themselves and now have a diabetic foot ulcer. Think of people with COPD who have not been taking care of themselves, who now are in respiratory failure unrelated to COVID. So I think in one way it's changed the patient dynamics that are coming in, and it's also changed the severity of illness. We are admitting about 20% more patients than we ever did in the past to the hospital. So the people we are seeing tend to be much more ill. And I think that anecdotally, that is a result of the decrease in primary care out there right now.
Thank you.
So I see a question in the chat, so I'll go ahead and grab it. So Jay said, I am unsure if you know this or maybe out of your field, but what kind of doctors are there on the EMT vehicle? Like when someone calls 911, who's on the ambulance? So that varies regionally. So I really enjoy EMS. I have a lot of friends that are in EMS. In the state of Maryland, there are two primary levels of care. There's what's called an emergency medicine technician and then what's called a paramedic. And so calls are dispatched by 911 as either what are called BLS, basic life support calls, or ALS, advanced life support calls. BLS calls can be handled by either a paramedic or an EMT. Advanced life support calls are only handled by a paramedic. Now, EMTs can assist them, but the paramedic must be present for that. There are not, for the most part, any physicians on ambulances in the state of Maryland. There's another chat question over here, Mackenzie McDonald. You explained your typical day, but before you did all the extra things with the company, when you were just a doctor, the glory days, what was the typical day like clinically and non-clinically for someone who's just a doctor? So when I was just a doctor, my day would be, seeing patients. I worked more shifts, so I worked more time clinically than I do now. But a typical day is, you're going to come into the emergency department. You're going to have patients sitting in rooms ready to be seen, hopefully, although that's been challenging recently. We have, for those that don't know, a nursing crisis on our hands. So we have a dearth of nurses at this moment. You would go into the room, you're going to see the patient, you're going to come back to your computer, you're going to put some orders in, the nurse is going to carry out your orders. If somebody comes in with abdominal pain, you might get blood levels on them and electrolytes on them, kidney function on them. You might get a CAT scan of their abdomen. You get all that information back, you reassess your patient, you determine if they can go home or do they have appendicitis. You might have to call a surgeon. You might have to call the medicine team, get them admitted to the hospital or discharged from the hospital. And in any given day in emergency medicine, most of us average seeing about 2 patients per hour. Doesn't sound like a lot, but when you're managing very complex patients, such as patients with heart attacks or trauma or sepsis or head injuries or all of these sorts of things, it actually is a fairly busy day. So you find yourself running around the department most of the day, and you hopefully clean up and get out of there on time. I think one of the great things about emergency medicine, one of the primary reasons that I love it so much, is that when you're on, you're on. And I mean, you're on. You are the center of the universe in that emergency department. But when you're not, you're not. And so it gives you time to do things like this, because I know right now I don't have a pager that's going to go off. I don't have any phone calls that are going to interrupt me from a clinical standpoint. Now that I'm doing non-clinical work, I have plenty of phone calls. But from a clinical standpoint, I know that I'm not going to get called to come see a patient right now. So when I'm there, I'm there. And when I'm not, I'm not. Hopefully that answered your question, Mackenzie. I see Jay's got another question. This is great, guys. The chat's a great way to do this, by the way. Are there any programs or shadowing positions that you know of that gives college students opportunities in the field of emergency medicine during the summertime? I have reached out to Dr. Verville many times in the past. If somebody has an interest, please speak with her and she'll get you in touch with me and we can have those discussions. I am more than willing to have people shadow me in the emergency department at TidalHealth Peninsula Regional. But we do have to go through a couple of things to get you certified to do so. You have to give your ID and get a badge and a bunch of stuff like that. But those things can be done. So if anybody's interested, Dr. Verville would be the person to go through. I have one here from Dom, and it says, can you explain the difference between emergency medicine in a hospital setting compared to private practice, if there is one? There absolutely is one. So the history of emergency medicine is that back in the day, the doctors who worked in the emergency room in the late 60s or most of the 70s and early 80s were typically either surgeons or family medicine doctors or internal medicine doctors that on their time off would come in and see patients in the emergency department. That changed in the early 1980s when emergency medicine became a board certified specialty. So we are our own specialty. So starting in the early 1980s, there began to be residency programs that trained doctors specifically to be emergency medicine doctors and not to work in the community at all. And so I am one of those people that has been trained in a residency program that is specific to emergency medicine. So right now, I really can't go out and practice in a private setting. I would need to do a different residency in either family medicine or internal medicine. My specialty now is emergency medicine. So when I go to work, I would only ever be practicing in an emergency department setting. With that being said, some people who do emergency medicine do ultimately decide that they want to slow their careers down a little bit, and they will go work in urgent care centers. So that does happen, but typically you wouldn't find an emergency medicine doctor who then did primary care.
I had a question that came in just to me, so I want to make sure we circle back to get
Sure.
that one. From what I understand about medicine in general, you may lose patients, but how often would that compel? So basically, how often does that happen for emergency medicine?
I would say if I probably work 13 shifts a month. I would say it probably happens 5 times a month, maybe every other shift.
I'm going to imagine the follow-up to that might be, how was that process, especially when you were first starting out? I assume now you can't say come accustomed to it, but certainly now you have the experience, but how was that initially?
Yeah, I mean, I think you have to remember that sometimes, when you watch TV, when you watch, popular media, you might think that every time that somebody dies in the emergency department with some tragic accident, sometimes it's just that somebody's time to go. So, of the people that are dying, it's not always something that's tragic. Sometimes it's actually something that is a relief to the patient and a relief to the family. And so, sometimes it's almost a good thing in a way. We try to get people home when we can. We try to get people in their homes with hospice. We work on those things. But, it's not always the worst thing that happens. Sometimes we absolutely have cases where it is a trauma, or it's a child, or it's, something that is quite intense. I think it takes you a lot of time to process those things, but I think over time you get better and better at it. And I think you also realize that just because somebody doesn't live in the emergency department doesn't mean that it was any particular person's fault that they didn't live in the emergency department. But at times it can be very challenging, especially with children and young adults, or things like suicide, things like violence and trauma. And you just do your best to handle those things when they come across.
I have a question. So how did you get involved with, you said you were an EMT?
Yep.
So how did you start doing that?
So funny question. It's a great question, actually, because you're like, how would I get involved with that? I think one of the things that you'll find with personalities in emergency medicine is that we're all a little type A. And so what I did is I literally I rode my bike actually over to the rescue squad and knocked on the door when I knew there were people there and said, hey, I'd really like to be an EMT. What do I need to do? And that's exactly how I did it. And I'm not even kidding.
So what, did they, of course, they made you go through training, but what did you have to do to be qualified or certified?
Yeah, so what happens is for the rescue squad, you have to be voted in, but if you have an interest, you're going to be voted in. It's a volunteer thing. And then you pay a fee and they send you to EMT school. And so when I was fall of my junior year, I spent every Wednesday night, I think it was, doing 4 hours of class in Galena to become an EMT. And I think the whole entirety of the class was 16 weeks. And then you have to take a practical and a written exam at the end. And then if you get through all that, then you become an EMT. And the remainder of my time at Washington College and the times where I would come back to visit my wife, I would run calls. So I'd have a pager. Dr. Verville probably remembers this very, very vividly. I'd have a pager. I kind of had some rules about it for myself that I wouldn't do it when class was going on or lab was going on, and would also take calls. So I would take call about 4 or 5 nights a month with the rescue squad. And that was probably the best time to learn, because you'd get called out on a weeknight or a weekend, especially, and get to do a lot of cool things. But yeah, and they sent me to class so that I'd learn how to drive the emergency vehicles, which was a lot of fun, actually. And they also have a boat program, so I got involved in that. I really enjoy boating now, and so it was a really good segue to some of the hobbies I have in life now. But yeah, that's how you do it. I think Brody Man here has a question. How did your view of medicine change before and after medical school? How would you recommend a first-year medical student approach their first year? I am going to tell you, it is very challenging that first year. There's no way to sugarcoat it. There's no other way to put it. That first year, you have to be just hands-on. The first 2 years, I almost think the second year might have been a little more challenging. You go from being a very decent student at Washington College to going to medical school and realizing that there's a lot of really decent students out there. I think that you approach it by, at least for me, the way I approached it was by taking it one step at a time and knowing that it was a marathon and making sure that you got through step A before you try to do step B. In terms of how did your view of medicine change before and after medical school, I think that a lot of people don't really understand what physicians do on a day-to-day basis. I think that there is a certain mentality that there's always a dramatic scene. There's always something going on where moments matter. And there are those times, especially in emergency medicine. But for the most part, I'm going to see abdominal pain patients and they don't have anything wrong with them, or a headache and they don't have anything wrong with them. And then, I saw the other day I worked a 9-hour shift and I basically didn't have anything interesting until I picked up that a lady had a ruptured aneurysm in her brain. And then my day got very interesting. So I think how my view changed is thinking that it would always be the most interesting case or the most dramatic thing or the biggest trauma or whatever, to understanding that it's not always that way. There is a certain amount of practice in emergency medicine and in medicine in general where you are simply seeing patients, and sometimes that can be the best part of your job.
I have another question. I know that it depends on like who comes in and what you're treating them for, but how long is a typical ER visit? How long do you spend with each patient?
I think those are two questions. I think one question is how long I spend with the patient and how long do they actually stay in the emergency department. So in our department, most people in the past, I will say pre-COVID, would spend about on average an hour and a half to 2 hours in the emergency department. Post-COVID and the current state that we're in now with the nursing crisis going on, people are definitely spending longer periods of time in the emergency department. When I went into work yesterday, we had 32 people boarding, meaning that they were admitted to the hospital and didn't have a bed upstairs. And the longest one, I believe, was there for 50 hours, so 2.5 days. And so people can spend a very long period of time in the emergency department. I think most patients that I see, I might spend 5-10 minutes with in total. I think if I have to do procedures, I end up spending a significantly more amount of time with them. For instance, if you have to do a lumbar puncture, if you have to do a chest tube, if you have to put a central line in, if you have to do these sorts of things, you're going to wind up spending a significantly longer period of time with them. So it really does depend on the patient. I think that we probably spend more time with our patients than a typical primary care doctor does, to be quite honest, because they actually have to see more patients in a day than we do. But their patients typically don't have the same complaints or complexities. Well, they might have the same complexities, but they don't have the same complaints as what we're seeing in the emergency department. So they tend to be able to get them in and out of the office quicker. So they might be there in the office for 20 minutes and they might see them for 10, as opposed to I might see them for 15 or 20 minutes and they might be in there for 2 hours. Hopefully that answers your question.
I had a question come in. Have you ever experienced a mass casualty event?
That's a great question. I have not experienced a mass casualty incident that has been declared a mass casualty incident. So those of us in emergency medicine will tell you that every Monday is a mass casualty incident. So for those that don't know, Mondays are our busiest day of the week, and that is true of emergency departments across the country. And so on Monday, we typically will see at least 30% more volume than we do any other day of the week on average. And so on any given Monday, if you already have the swell of volume that you typically see on a Monday, you get 2 or 3 traumas. All of a sudden, you basically have a mass casualty incident because you have needs that overrule your resources. So I've not been a part of something such as a mass shooting. I've not been a part of a building collapse. I've not been a part of those things, but we've definitely had periods of time where it seems as though we are being overwhelmed. Great question.
Do you have any other questions?
Well, thank you all. And if anybody does have any further questions, Dr. Verville can absolutely get you in touch with me. I'm happy to have people shout at me if they are interested. Just please use her as a resource. And if anybody has any further questions, feel free to email me.
Clarify that so TidalHealth is currently doing shadowing. Is that correct?
I believe so. Don't hold me to that 100%. But the last I had heard, yes. But we went through a period of yes, no, yes, no, yes, no. So my most recent is yes.
Yeah, because I had been looking around, and I think they still had their whole process, and it was still on the website. Nothing said that they weren't right now, and frankly, that might be the closest system to us that is actually currently accepting shadowing. So, at least in terms of hospitals, obviously there's private practices, here and there that are doing it, but that is certainly good to know. I'll appreciate your willingness to do that. So thank you.
Absolutely.
Okay, well, thank you for joining us tonight, and if you have any final thoughts, but other than that, we'll let you go for the evening. Enjoy your day off tomorrow. I'm sure you're right back at it on Thursday.
Yep, absolutely. You guys have a wonderful night. Enjoy Chestertown, and talk with you all soon.